The urgent need for evidence on measures to respond to the COVID-19 pandemic had led to a rapid escalation in numbers of studies testing potential therapeutic options. The vast amount of data generated by these studies must be interpreted quickly so that physicians have the information to make optimal treatment decisions and manufacturers can scale up production and bolster supply chains. Since many physicians are currently using treatments that rely on compassionate use exemptions or off-label indications to treat patients with COVID-19, it is crucial that they have access to the most up-to-date research evidence to inform their treatment decisions. Good evening and welcome to a COVID-19 webinar, Clinical Management of COVID-19 Patients. Tonight's event is being brought to you by the PAHO-WHO Bahamas and Turks and Caicos Islands Country Office, the Ministry of Health and Wellness, and the Medical Association of the Bahamas. To begin this evening's event, we will now call Dr. Cindy Dorset, President of the Medical Association of the Bahamas, to open us up in a prayer. We will now have one of the representatives for the Medical Association of the Bahamas to open us up in a prayer. We'll now at this time call the Vice President or the Chaplain. Until then.
Good evening, Tanya. I wonder if we have to allow them to open their microphones. She's trying to speak.
We will ask our host to please assist Dr. Dorset with opening her mic to lead us in a brief prayer.
Tanya, give me 1 minute. If you can type the name on the chat so I can add him, please. Thank you.
Sure. And please let Dr. Dorset know when she should try again. Email. Dr. Dorset, can you type your email into the chat for us, please?
What we will do is we will come back to our prayer, and we will now have the remarks by Dr. Eldona Boisson, the Pan American Health Organization and World Health Organization representative for the Bahamas and Turks and Caicos Islands Country Office. Dr. Boisson.
I'm sorry, can you hear me now?
Oh, yes, now we can hear you, Dr. Dorset.
Okay, yeah, it just came, an unmute signal just came up. Okay, so good night to everyone. We thank you, Heavenly Father, for a new day and another opportunity to connect in a professionally collaborated effort. We invite you in our midst. Grant us expanded wisdom and discernment as we seek to create solutions for the care and well-being of our loved Bahamaland. Bless the speakers and presenters tonight. Bring clarity of thought, O God. Let all that is done always bring you honor and glory. In Jesus' name we pray, amen.
Amen. Thank you, Dr. Dorset. We will now have brief remarks by Dr. Dr. Eldona Boisson, PAHO-WHO representative for the Bahamas and Turks and Caicos Country Office.
Good evening, everybody, and a warm welcome to this evening's session on clinical management of COVID-19 cases. We are really happy to have all of you here tonight. I see we have already 127 persons here. When we engage with Dr. Dorset and the rest of the board of the Medical Association to have a discussion with them about having a session with the membership. They were very excited, and we had quite a discussion, actually, almost as long as a webinar, to discuss what we thought might be most appropriate and most useful for you to hear about this evening. What we want to say is that this is not going to be necessarily the last session. If there is an interest in additional topics, certainly we can have additional sessions, but this first one was the one that the board thought was of most importance to you at this time. So I encourage you to take full advantage of our speakers. We have very experienced speakers with a lot of experience, not just regionally, but even in the Caribbean. We have somebody from Barbados. I also want to add that when I discussed with Minister of Health that this session was taking place, he was very, very keen to be part and to be able to have the opportunity to address you. So we hope that this collaboration is actually the first of many more to come. We hope that you find it very useful and that you are able to get all your questions answered. We have also shared some references with you, so I encourage you to go and refer to those after the session. So thank you so very much for being here with us this evening. And I turn back over to you, Tanya.
Thank you, Dr. Bassan. We will now have remarks by the Minister of Health and Wellness, Dr. Michael Darvo.
I see Minister Darvo is muted. I don't know if we can get some assistance for him to unmute.
PWR Bassan, good evening to all. Minister
Good
will
evening.
be, yes, Minister is here. Just hold one moment, please.
Okay, thank you.
Thank you. And as we await the remarks of Minister Darvo, we just want to remind everyone that this evening, there will be a question and answer period. So feel free to post any questions. At the time, you would also receive further instruction, whether you can, in regards to unmuting your mic, to ask your questions and to have your questions answered from the experts. Thank you again for your attendance this evening. Welcome, Dr. Darvo.
Well, good evening, everybody, and sorry for being late. What we have is a situation, excuse me 1 minute. Guys, you have this echoing. Please forgive me. I had to step out of cabinet, and the place where I usually set up for my Zoom conferences, I was unable to do today. And so first of all, thank you for your patience. And to this evening, I bring greetings from our Prime Minister. As you're aware, we recently elected a government and we have been in office for about 8 weeks. And as Minister of Health and Wellness, I was catapulted in the middle of a pandemic that was burning throughout our archipelago. Now, I see where we have representatives from the Bahamas, as well as some representatives from other parts of the Caribbean. And so I would want to say welcome to everybody. COVID-19 is something that all of us have experienced. And from what we're understanding throughout the world is something that we would have to encounter for many years to come. The Bahamas is no exception to the rule. We are an archipelagic nation of some 700 islands and 2,000 keys. And we extend 60 miles from Florida to 60 miles from the island of Hispaniola. For us, battling COVID in an archipelago is a unique challenge because of the logistics that is involved. A good example is one of our islands further south is called Inagua. And so when I became minister, I came in with a major cluster of COVID-19 on our most southern island that has about 900 to 1,000 population size. And we had a substantially large cluster that needed immediate attention. I don't know about your countries, but for us, we're presently in the emergency orders where some aspects of civil liberties are affected, and we have the capability to go into curfews and movements of people can be affected. On coming to office, that particular island, we had an influx of about 1,000 immigrants from the island of Hispaniola, mainly Haiti. And we were confronted with a major cluster while simultaneously dealing with repatriation and the control of illegal immigrants. It proved to be very difficult for us because movement of essential supplies like high flow oxygen tanks and all of the necessary medications to treat those individuals who may be suffering from mild to moderate symptoms of COVID-19 became a challenge. Because in the midst of a pandemic, our defense force had to revert their attention to a migration of individuals coming into our country. And that is a good example. Our capital, or our New Providence, which is about 700 miles to the west, northwest of Inagua, was affected. And we needed the defense force in order for us, excuse me 1 minute. To assist us, sorry about that, to assist us in the movement of essential supplies, which made life even more difficult for us to be able to fight a pandemic in an archipelagic nation where the capital are sometimes 700-800 miles away from our most southern flung islands. So we have been battling COVID not only in New Providence and Grand Bahama, two islands with the largest populations, but we have begun to see COVID throughout our archipelago and the complexities and the logistical challenges necessary in order to fight this infection. To compound that, like every country, I would think in the region, we have very high cases, and we started to have issues with the inability to provide the necessary services to the best of our ability at our tertiary facilities for those who became moderately ill and some of those who are severely ill and needed intubation. With that being said, we are quite fortunate now that our numbers are actually falling. Our hospital rates are declining. And now we, like every country in the world, have to find ways on how to open our economy to ensure that we begin to get our businesses up and functioning and to allow our tourism sector to begin to come back to its pre-COVID days. That is happening in our country now. And we are now preparing, because the world is now preparing for the possibility of a fourth wave, and the Bahamas is no different. And so we are now looking at our healthcare infrastructure, our clinics, and also for additional a field hospital that would be necessary in the event that we do have a fourth wave. The Bahamas would be better prepared than we were for the existing wave or the wave that just passed by. For us, we are looking at new ways on fighting COVID. We look at COVID and the prevention, and look at avenues on how we can do something to ensure that our people are able to implement strategies as it relates to prevention, and then early detection, and then finally those who have to be hospitalized to go into our tertiary facilities. For us, it is a difficult task And it's a difficult task because our healthcare system have been compromised, not operating at its full potential for many years. And with the burden of COVID, all of those small holes that exist are now becoming gaping wounds. And for this administration, the challenge is to move swiftly to get our healthcare infrastructure up to a point that we would be able to do a better job in the fight against COVID-19. With that being said, I know that we have a wide cross-section of speakers on the ways on how we should move to deal with the pandemic. But for us, another area that we're looking very closely at is to ensure that we have additional medications that will be able to help us so that we can get better medical outcomes and reduce the incidence of death as a result of COVID-19. We have a very good team here at the Ministry of Health. We have an excellent vaccination program that is ongoing, and we're looking at it very, very closely to ensure that we are able to take the country from where we are now at about 40% vaccination rate, hopefully to get us within the 200,000 range, to be able to have a better way of dealing with the outcomes of the pandemic, because the science is absolutely clear. And we have noticed it from the literature at our tertiary facilities that the bulk of individuals who present themselves with advanced disease of COVID-19 are individuals who are unvaccinated. And for that, we are now establishing greater PR protocols and ways how we can get our population vaccinated in the shortest period of time. Now, for 40%, I realize that WHO target for the year for 2021 is for countries to get at least 40% vaccinated. We will reach that stage, but we need to go even more, and we need to do it very rapidly. So the largest centers for vaccinations that are currently existing in our country, we are now breaking them down into smaller groups, and we are actually going directly to the people and vaccinating them where they are rather than them coming to us. One of the challenges that we found is that we assume that everyone is computer literate, and we assume that they have access to the World Wide Web and can go online, but we are realizing that even though we have people in our country who have access to the internet and have a smartphone, some of them do not have the skills to be able to go online and to fill out the necessary application and to book an appointment. And so we're going to make life easier for them while we go to them and we do this particular thing for them so that they can get vaccinated in the shortest period of time. We have a good supply of vaccine in our country. We have Pfizer donations from the Americans, and we have it all over the country, throughout our archipelago, in Grand Bahama, in New Providence, and all of our southern, central, and northern family islands, where our clinics are directly involved in the administering of the vaccine. And we are now in communication with the private sector physicians and clinics who can be a part of the administration of the vaccines going forward. We look forward for good results in the near future, and to look optimistically to implementing new modalities of medications and drugs that we feel that will help us. We are now in the process of finishing the pilot projects for our free testing. And when we launch free testing throughout the Commonwealth of the Bahamas, we will be doing it simultaneously with a digital platform that ties testing directly into contact tracing. We are pleased with all of our passengers coming in on cruise ships. All of the passengers are vaccinated, and they need to have rapid antigen tests prior to disembarking and interacting with local populations in sporting events, in our restaurants, and the list goes on and on. And so with our tourism numbers going up, our cruise ship numbers going up, It's very important for us now to ensure that all of the essential public health protocols are adhered to, and everyone that's in the tourism industry needs to refocus and to ensure that they follow the protocols very closely. We're doing it in the Family Islands, and we have ramped up our enforcement agencies in our Family Islands because we were getting word that some of our tourists were not focusing on the healthcare protocols and assume because they're vaccinated, they are secured. But we all know the science. You can be vaccinated and you can also spread COVID and even be a victim of COVID. And so with that being said, I think that we have an excellent panel, and I would not be able to be a part of it, but I'm sure some really fresh new ideas will be shared. And I'm looking forward to discussing it with the representative of PAHO so that we would be able to implement anything that is new and that is working effectively in countries outside the Commonwealth of the Bahamas. I thank you for this opportunity, and we look forward to working closely with our international partners, individuals and companies, as well as our healthcare providers in other CARICOM nations, and to be able to pull resources as well as knowledge from everyone so that at the end of the day, as CARICOM, we can definitely show the world that we not only have the capability to fight this pandemic, but be able to do it in a sustainable way and allow our economies to function while at the same time protecting lives. Thank you, and thank you for the opportunity.
Thank you, Minister Darvo. And again, we want to say a special thank you and welcome to all of our persons who are attending this evening for our COVID-19 webinar, Clinical Management on COVID-19 Patients. We ask that, I see that some questions have already begun, but we want to remind persons that the questions will be answered at the end of the session in our question and answer segment. So now we will go into the gist of it, what we all have been waiting for. Our first topic this evening is updated evidence on the pharmacological management of COVID-19 patients. This will be done by Dr. Ariel Iskovich, consultant for the Pan American Health Organization and World Health Organization. Dr. Ariel?
Good evening to everyone. I will share my screen now. Please let me know if you see my presentation.
Yes, I can see your presentation.
Perfect. Well, so I will get started. My name is Ariel Iskovich. I'm a clinician. I live in Buenos Aires, Argentina. And the idea for this brief presentation is to revise the management strategies for patients with COVID-19 and non-severe state. For this, I will revise mainly two documents. The first one is the one I'm showing, that is it's a clinical practice guideline from the Pan American Health Organization for the management of patients with mild and moderate COVID-19. And the second one is a living systematic review on pharmacological treatments for COVID-19. I will start with this one. The first part is related to how we define patients with non-severe COVID-19. And this is something that has been proposed by the World Health Organization and acknowledged by other organizations, including the Pan American Health Organization. So non-severe patients can be divided in two: mild patients, which are symptomatic patients meeting the case definition, but without signs of viral pneumonia or hypoxia, and moderate patients that also don't have hypoxia, but have signs of pneumonia. So the first thing that this document provides is some guidance on the general management of patients with COVID-19. In this case, we have a population with severe disease that is shown in the pink boxes. And then we have the ones that we are focusing on in these presentations, which are the patients that have a non-severe disease. And as I told you, these patients can be split in two major groups. Those are the ones with mild disease. And in this case, also patients with mild disease and no risk factors for developing severe disease. And in these patients, the guideline suggests that can be managed at home, obviously with adequate monitoring, but at home and not in hospital or other facilities. In the other hand, we have patients that don't have a severe disease, but have some risk factors that put them in danger of developing a severe disease. The risk factors are listed here, and when we suspect that this patient is at increased risk, then the management can be done in different places, like, for example, tertiary facilities, hospitals, or other places instead of home management. This slide is similar to the previous one. In this case, we have, again, severe patients, which we will not talk about here. And then we have the non-severe patients that can be split in basically in two big groups. First, we have the ones that have mild disease and don't have any risk factors that provide us some idea that these patients can develop a severe disease. And so in this case, we monitor them without a lot of complex management interventions. And on the other hand, we have patients with moderate illness. Those are patients with pneumonia, but not hypoxemia, or patients with mild disease, but with risk factors for developing severe disease. And those patients, the guidelines suggest, can be managed in hospitals or other institutions with more complex capabilities. So especially these patients should be monitored for severe disease development, and obviously we need to consider oxygen therapy and other support that is necessary. So this is general management for patients with COVID-19 with non-severe disease. Now I will go into pharmacological management, and for that, as I already told you, I will refer to a different document. This is a systematic review that we are working on since the beginning of the pandemic. And the objectives of this systematic review were basically three. The first one was to collect the best available evidence on pharmacological interventions for patients with COVID-19 or exposed to SARS-CoV-2, sorry. Second one was to sustain a living update process in which every new piece of evidence is rapidly incorporated to the review. And the third one was to analyze the evidence using standardized and state-of-the-art tools. So for doing that, we have an association with Epistemonica's Foundation, which provides a system for identifying new studies that are coming out every day and select the ones that are relevant to be included in our reviews. They are doing a great job. There is now empirical evidence that very little information is avoiding our detection process. So we are very confident that we are identifying all the relevant information in a day-to-day basis. Then every piece of information that is incorporated to our review goes through the grade assessment process, where we combine the results of different studies and then summarize those results in summary findings tables that include the estimates of effects and the certainty of the evidence assessments. So this is the results I'm showing is the ones that are published in our last update. We have now incorporated 445 randomized control trials and an additional 7 non-randomized trials for one specific question. Our review is mainly focused on randomized trials. And as you can see, for our second objective, we are updating our review in a periodic basis, more or less, where our review is updated every 2 or 3 weeks. And the last update is from September 28th. Sorry, October 28th. So our review has a graph, a table that provides a summary of all the results included in our review. And this is, I will drive you through this graph. The first column is the intervention analyzed. We have now included more than 140 different interventions assessed in randomized trials. So this is a part of the list, the first part. Then we have a second column where we show how many randomized trials are providing information on that particular intervention. And these interventions are sorted according to the number of trials. So as you can see, hydroxychloroquine is the intervention that has the biggest number of trials reporting. In this case, 51. Then we have ivermectin reported by 33 trials, and so on. And then we have 6 columns that provide information on the 6 outcomes we are assessing in our review. The numbers you see there is the number of trials reporting on that particular outcome, and then you see some colors. The colors are the interpretation of the results that we are providing. So red is that the intervention is harmful, green is that the intervention is beneficial, and yellow is that the intervention is nor harmful nor beneficial. So as you can see, for example, for hydroxychloroquine, we have another thing that I forgot to tell you is that beside the color, we have an intensity. When the color is intense, it means that we have moderate to high certainty in that effect. And when the color is light, we have low certainty in that effect. So for example, for hydroxychloroquine, we have moderate to high certainty that there is a harmful effect on mortality. And we have moderate to high certainty that there is no effect on invasive mechanical ventilation, and so on. And for example, with corticosteroids, we have moderate to high certainty that there is a beneficial effect on mortality and invasive mechanical ventilation, and so on. So we have this done for all the 140 interventions included in our review. And as you can see, most of the intervention have gray or dark or black color, which means that we have very low certainty evidence. So we cannot, gray means that we cannot make or reach any conclusions because the certainty is very low. And black means that we don't have any information for that intervention and on that particular outcome. So as you can see, for most of the interventions assessed in randomized trials, we don't have enough information to conclude if the intervention is effective or harmful. So now I will go into the interventions for which we do have enough information to make conclusions, which are the ones that are represented here with colors. And I will split the results in 2 different groups. One group is the studies or interventions that have been assessed for patients exposed to SARS-CoV-2, but that are not ill, that have not contracted the disease yet. And in this case, the interventions are instituted with the idea of preventing the disease. And for this group of patients, or for this clinical scenario, we have hydroxychloroquine that has shown no benefits with low certainty, ivermectin, for which we have very low certainty, so we cannot say too much. And then we have 2 monoclonal antibodies. One is a combination of 2, Regeneron. You probably have heard about this one. And in both cases, these monoclonal antibodies have shown to reduce the number of patients that develop the disease when used in exposed individuals. The other clinical scenario is the one that it's the patients that have the disease but have a mild disease. And in this case, we have a lot more of interventions assessed. Hydroxychloroquine, no benefits with high certainty. Ivermectin, no benefits, low certainty. Lopinavir, ritonavir, no benefits with moderate certainty. Colchicine, small benefits, but low certainty. This is controversial because some studies have shown benefits and others have not. And this is something that needs to be addressed with more information. Steroids have not been assessed in this clinical scenario. Azithromycin also has not been assessed. And then we have inhaled steroids, where we have found small benefits in terms of how fast the symptoms are resolved. Patients that received inhaled steroids had faster symptoms resolution than those that did not receive those interventions. And then we have sotrovimab and Regeneron, that are two monoclonal antibiotics. In both cases, these interventions have shown to reduce hospitalizations in mild patients with moderate certainty. Then we have fluvoxamine, that it's an antidepressive medication, who also has shown a small effect in reducing hospitalizations, and this is based on moderate certainty evidence. And finally, oseltamivir, not assessed in this clinical scenario. I will show you some more detail for some of these interventions that you can find interesting. In this case, what happened with steroids, as you already know, systemic steroids are one of the interventions that have shown to be effective in severe patients. But as this slide is showing, the effect was not replicated in patients that have not a severe disease. The patients that did not need oxygen were not benefited by systemic steroids. So this slide is showing what we know about steroids, including patients with severe disease. And as you can see, steroids reduce mortality and invasive mechanical ventilation in severe patients. But as I already told you, we don't have information on what happens with steroids when given to non-severe patients in terms of reducing hospitalizations. Ivermectin is an interesting case because there is a lot of studies providing information, but most of the studies do not report on clinically important outcomes. And as you already know, there is a great controversy on ivermectin. And what we have found is that there is a group of studies that have significant methodological limitations and a group of studies that are more methodologically sound. And if we compare the results of those groups of studies, they are significantly different. The studies that have significant limitations suggest that ivermectin is useful, but the studies that don't have significant limitation or have less methodological limitations suggest that ivermectin is not useful. So we decided to base our conclusions for this specific review in the studies with less methodological limitations, and doing so, our results show that ivermectin possibly does not reduce mortality or invasive mechanical ventilation, but we should ascertain that the certainty of the evidence is low and the question is open and we need more information. For time to symptom resolution, we have a little more certainty, and again, it doesn't appear to be useful. And for hospitalization, again, we have low certainty, so the question is open, but the evidence suggests that it might have some effect in reducing hospitalization. Azithromycin has not been assessed in mild patients, and in severe patients, it didn't show significant benefits. And then we have monoclonal antibiotic or the combination of two monoclonal antibiotics. As I already showed you, these antibiotics have shown benefits in patients with mild disease, and in patients with severe disease, it has also shown benefits, but only in seronegative patients, patients without antibiotics against COVID-19. So the summary of the effects of this therapy is in patients that are seronegative, we have a reduction in mortality and invasive mechanical ventilation. And in patients that don't have a severe disease, mild patients, we have, as I already told you, Regeneron reduced the number of patients that require hospitalization. The amount of patients that reduce that per 1,000 patients, more or less 50 patients less will require hospitalization if treated with Regeneron. And well, we didn't find significant adverse events related to this intervention. Then we have another monoclonal antibiotic with similar results. As I already told you, this intervention also reduced oral hospitalization in mild patients, and also it reduced the number of patients that developed the disease when exposed to SARS-CoV-2. So as a summary of our findings in the review, we have 4 different clinical scenarios. The first 2 are the ones that are relevant to our presentation today. These are non-severe patients, and we have those exposed to SARS-CoV-2, but without the disease. And in this case, we have 2 monoclonal antibiotics, one monoclonal antibiotic and a combination of 2. And in both cases, with moderate certainty, we have evidence that those are effective in reducing the number of patients that will develop the disease. Then for mild patients, we have inhaled steroids that have shown to reduce the number or the length of symptoms. Then we have 3 monoclonal antibiotics that have shown to reduce the number of patients that develop severe disease and require hospitalization, and 1 more intervention that is an antidepressant medication that have also shown to reduce the number of patients that require hospitalization. And then for severe patients, although it's not our focus today, we have systemic steroids, tocilizumab, baricitinib, and also Regeneron in patients that are seronegative. So based on our findings, the clinical practice guideline from the Pan American Health Organization provides these recommendations, and the recommendations are the following. For prophylaxis, do not use any drug for prophylaxis in persons at risk for COVID-19. For pharmacological treatment, it is recommended not to administer any drug, ivermectin, hydroxychloroquine, antibiotics, or steroids, among others, for the treatment of patients with mild and moderate COVID-19. Supplements, it is recommended not to administer any supplements such as vitamin D or chloride dioxide for the management of patients with mild to moderate COVID-19. Then there is a clarification, and it says that the World Health Organization formulated a conditional recommendation for the use of Regeneron in patients with non-severe COVID-19, specifically for those with higher risk of hospitalization. The Pan American Health Organization panel discussed and considered the context of Latin America and the Caribbean, and suggested that each country should evaluate the decision for use based on available resources, feasibility of implementation, and access. It is important to determine that the criteria for identifying patients at high risk of hospitalization, the capacity of services to administer the drug, and the appropriate time to initiate its administration. And lastly, treatment of co-infection should be based on diagnostic confirmation and clinical criteria following institutional protocols. And just to, this is the last slide. This is the slide summarizing the recommendation from the World Health Organization. And as you can see, they divide their recommendations according to the clinical scenario. And for patients with non-severe disease, they suggest this is a weak or conditional recommendation for the use of Regeneron. And then they don't recommend using ivermectin, hydroxychloroquine, lopinavir, ritonavir, or remdesivir. Also, they don't recommend to use steroids. Thank you very much. I hope this was useful for you, and I'm open to questions when it's the moment.
Thank you, Dr. Ariel. We will now have our next segment will be led by Dr. Corey Ford, infectious disease physician at the Queen Elizabeth Hospital in Barbados. And the topic is country experience, clinical management of COVID-19 patients. Dr. Ford.
Thank you, and good evening to everyone. Thank you for giving me this opportunity to give a presentation based on what has really transpired in Barbados over the last almost going 2 years. And I imagine for most of the Caribbean, certainly this has been a real trying time. So I'm going to look a bit at the epidemiology of COVID-19 in Barbados. I'm going to look at the operational response to COVID-19 in Barbados and a bit of the clinical management, and also look at what are some of the challenges that we would have faced and kind of factor and shape the management practices according to what has happened, certainly with the advent of Delta, and what we might really look at in the Caribbean in the future. And we know that in terms of fundamentals of COVID-19, we understand its transmissibility. We've understood globally the severity and the effect it's had on populations. And I keep mentioning all the time, the number of cases is important, but certainly most countries were ravished globally, including in the Caribbean. We were certainly not spared in terms of the amount of persons who actually got sick. And I keep saying that one of the greatest challenges the world has faced is the amount of sick people that has really plundered our healthcare system. And that's the impact. So I think one of the challenges, and with every challenge, many things can ensue. And if we looked at Barbados back in the 16th of March 2020, almost feels almost like 10 years ago, but really just around the corner. The important things in terms of our program and in terms of how we fought COVID and continue to fight COVID as of today is in terms of leadership, teamwork, and resilience. And I can't really impress on the importance of that sort of teamwork spirit in terms of getting to control or to have the effect on COVID as you might want in the healthcare system. So I think the operational response is based on stuff and space. So what we've done was a bit different to the rest of the world. I think we recognize we only had one general hospital, basically for 290,000 individuals. And we understood and saw what happened across the globe. And I think that remains a very important point, that if you see what's going on across the globe, yes, there were challenges in terms of the amount of healthcare workers, but we recognize that our biggest challenge would certainly have been the absence of having another healthcare facility to provide the care that we wanted to if our own major healthcare system was overrun with COVID. And so apart from starting, we had on the ground at the start, what we call the Enmore building, which is over here, which only had 6 beds. And looking back at that, it was kind of a joke right now to what we were accustomed to. So we went into schools, went into our military base, and we developed healthcare facilities. We actually were able to put this down in 24 hours. But ultimately, the aim was to really build a healthcare facility which can handle COVID, and for that matter, any other infectious disease that might come. And we certainly were able to do that, again, Again, the prevailing team here, and I think prevailing team needs to be for all countries across the Caribbean, is a unified team effort, a real whole government approach, as opposed to just a Ministry of Health approach. And this has really led to our Emergency Operations Center, which took into essence not only health, but really all different sectors as we were dealing with what we would call a national disaster situation. But I think one of the important things to remember, and we really, and one of the things I really stress, certainly as infectious diseases and infection prevention control consultant, was to say, look, whatever facilities are built and however a response is to COVID, it's really going to be an infection prevention based mechanism that has to be very, very airtight. And then went back to the basics, the elimination, the engineering controls and making sure that they're in place, the administrative controls. And one of the things that everybody freaks out about, but certainly is important control, but has the less effective measure, is the event of personal protective equipment. I think certainly in the early part of the break, we kind of did well with personal protective equipment because we had, I think before we had recognized what was going on globally, we were able to have a lot of stock on the ground. But I think for most countries, looking and seeing what was going on, things were going to be different. We're going to do things quite a bit different than we were doing before. And I think multiple simulations in many specialties, whether it be obstetrics, whether it be the neonatal intensive care surgeons, for example, anesthesia, which became an important part, things that were done before would obviously have to be changed at that particular point. But I think we look back then and look now, and we certainly have learned from COVID in terms of how it spread, in terms of you know, the capacity spread by contact and how that's certainly changed in terms of dynamics. And of course, the capacity spread by droplets. But I think for most countries, and what we've done was really to look through what the WHO type protocols for each area and try to really mince it into what we had available in country and try to have as best practices possible. But I think we also looked across many sectors, and we allowed each division and certainly in the hospital to come up with their own protocols for the country, and we assessed it certainly from the infection prevention control status. So I think this was defined before, and I think it's very important that countries really obviously define this, and Barbados did something which is quite different to the rest of the globe, and I think really accounted for certainly the first part of the outbreak, and certainly the second part of the outbreak, for the low amount of deaths that we would have seen compared to many countries across the globe. We did come with something a bit different, which is really to isolate all patients with COVID-19. Certainly the Alpha and the Delta, that will change, and I'll talk about that later. But certainly in that part of the outbreak, it allowed us to isolate individuals. And that was based on local experience. And I think all countries, despite what's going on globally and recommendations, one has to really mince what they do according to what's going on within the actual population. And recognize in Barbados that people live very close together in households. Sometimes multiple people live in households, and there are many young people in the community that we know certainly that, you know, if you ask them to stay home after about 2 or 3 days, they probably won't. And then we have to look at the capacity to maintain that isolation status or home isolation status. And that was different. So I think we define these areas which allowed us to put people in facilities according to where they were stratified. So certainly if you were critically ill or severely ill, you will go to our major premier isolation facility. If you're moderate to mild disease, we'll kind of monitor you. But what we've learned certainly in the process is something quite different, which, and I don't know if it's been touched on at all, but certainly from our own experience is that I often worry, and it's going to sound a bit strange, I often worry about those persons who present as asymptomatic. And I say that because I often recognize, especially in young people, that can change extremely quickly. So just give you an idea of what has happened in Barbados. Certainly in the first part of it, but we look more, you see this data coming out to the US back in March. And when we started our journey, you see our curves in terms of distribution of cases look more in tune with what was going on within the US at that time. And if we look then and compare that to some of the early studies in China, for example, again, we look more like them, but we were seeing less severe to critical disease, unlike which we saw more mild cases, certainly in the first part of the outbreak. If you looked in Barbados and we look from then, certainly up to this period, our deaths up until recent, mind you, and this data is up until I think the end of August, if my memory serves me correct here. But we looked at the data, and of course, the lines look exactly like almost the rest of the globe. We had less people certainly dying in the younger population. And we've seen changes in this since September, and I'll update that at some point. If we think about comorbidities in Barbados in terms of deaths in our experience, again, not unfamiliar. So diabetes and hypertension is not something that's unfamiliar in Barbados. Probably looks like the normal population in terms of presentations. But certainly when we looked at the comorbidities and deaths, diabetes and hypertension obviously were topping. But I think maybe confounded by the fact that they're quite common in the populations you see affected in terms of the deaths, as I presented before. And I think this is a very important slide. It's probably more up to date than the previous slides I've given. And I think what we've recognized, certainly, and one of the things I'm really drumming home, certainly in our population, is to recognize where our challenges. And I think every single country in the Caribbean needs to recognize where the challenges in terms of the vaccination population. And we've recognized, because I think we have a unique stuff where we really centralize all of our persons who are positive for COVID. So we have a great idea of what's going on in terms of all the different entities, whether they're diabetic, whether they're hypertensive, all the comorbidities, the age groups become important. And one of the things we looked at, certainly from February to now, is to recognize that the population really does being presented, certainly for admissions, even up to now, remains this population, which is between the age of 16 to 31. And what you might recognize that population is that's healthy working population, people who move a lot. But I think I don't have on this slide, but I wanted to cross-hatch it, but I didn't have enough time. But that's also the population in country which is the least vaccinated population, which I think countries need to look at this and then find out strategies as to how they can uplift their vaccination program within this area. We've come up with some unique ideas in terms of using some more popular people on the ground to try to push vaccination statuses within this population, recognizing certainly, if you look at this quite clearly, that certainly that it has been a challenge throughout our outbreak consistently, even when the numbers were down. So one of the things we recognize, even before we got our first information back, certainly from CARFA, indicating that Delta was present, one of the things that we recognized, we got more of it, we saw certainly about from August the 20th, an increase in the amount of persons who were being placed on oxygen. This is something we had not seen before, certainly with any sort of STED during the outbreak, which is quite different to the rest of the world. But again, I believe that was because we were able to isolate everyone, and people, as soon as they got sick, we just pulled them out, instituting the appropriate management. And then I don't think people got to that stage where they're critically ill, requiring a lot of oxygen or ventilation. Never really had that challenge. But that certainly has changed when the numbers certainly grew. And then we moved to the whole idea of home isolation. I always said we would look like the rest of the world once we moved to that stage. But we were able to pick up, obviously, increasing amount of oxygen being used, increasing amount of people on ventilation, and it correlated certainly with the amount of admissions to facilities. And so we had to really contextualize things, kind of change, how we were thinking. And any battle, I consider COVID to be a real war and a battle for every country. And one had to re-strategize, how we do things. So yes, we were admitting everyone before. Now we had to really rethink. This became the idea of using a concept, which is really now classifying those who are positive into three major groups. So they're the green, which means you have, you're asymptomatic or have very mild disease. Yellow, you have mild disease, but you have comorbidities, and certainly you're unvaccinated. And if you're sort of red, it means that you had several flags of it in tune. So people who are thought to be unvaccinated, multiple comorbidities, or vaccinated with significant severe to moderate symptoms, whether shortness of breath or what's not, then you're classified in that red group and you're brought to the admission facilities for evaluation. There's some people who might be evaluated and sent back into home isolation, which is telephone evaluation. But after they come in, one decides where they go within the facilities, again, based on where they're at. So we had to totally re-strategize what we did, and that was done pretty quickly and effectively. I think making local management decisions in Delta has been quite different, certainly to the first two waves. And I believe that we'll continue to have to change to change things according to your local environment. So clinical management certainly has not changed. It's quite in tune with what was mentioned before. I would say that I'm under a lot of pressure to use drugs such as ivermectin, and I've been very resistant to do that. Just merely because of the evidence. I think most of my professional bodies, including Infectious Disease Society of America, WHO proper, would not recommend them, and I certainly will fall in line and keep in line with that. But I think one of the things that countries need to look at, certainly when you get these sort of numbers, certainly respiratory and circulatory support recognized as critical. Having an ethics committee in terms of dealing with that aspect becomes important. It's something that we've set up. But I think it will always remain a challenge, making those decisions as physicians, it really is a difficult one. Physical and human resources, we're able to gain the help of the Guineans, Cubans on the ground, and because really we had limited ICU nurses, so we had to really, again, in this part of your bit, re-strategize. And if you heard me speak last time, you heard me say things a little bit different this time. One of the things we did, and I really would really encourage many of my Caribbean colleagues to do, is to really rethink your healthcare system. So there are many things that nurses do and doctors do that other people can do if they're trained to do them. And I think if you continue to try to find the amount of nurses to do swabs or doctors to do swabs, your system will fail. I think one of the things I really impressed, certainly in the Ministry of Health, is that we cannot do things the way we did them because this is not normal times. And we were able to train people who were probably employed as orderlies and housekeepers and people who were interested or could develop a skill to do other skilled events and train them over a period of time to do swabbing. So no longer is it now only for medical people, but we use a whole cohort of different persons to function. We are able to expand our training in key areas, which will cut the work down for the doctors so the doctors can do things doctors can do. So one of the things we're starting working on right now is phlebotomy, certainly, and expanding that to non-medical personnel. But some other essential things that doctors might find themselves doing or nurses might find themselves doing. I think countries need to repurpose what they do and kind of look certainly at letting nurses give medication and do the things nurses do. So I think some as vitals, we're able to train a whole heap of what we call now client aides to do vitals across the system. And report it in, and they're assessed by nurses and subsequently assessed by doctors. So the doctors can do things that doctors can do. Knowing that you only have a smaller capacity of doctors or nurses within your system, and you have to still make the system work. Of course, there'd be lab challenges. In initial phase, it was a difficulty even getting an FBC or UNE. I think that has changed, and I think we've become more comfortable, not fully, but more. Community involvement process becomes very, very important. I think we took this fight to the community in the second wave, and we're doing that currently in the current wave is what we call Operation Seek and Save. So there's some people who don't want to come out because they're just afraid of facilities. They're afraid because social media says this drug they give you and it kills you. And the battle is really for us, not only in trying to fight and save lives, but certainly at the level of the impact of social media across, I think, the Caribbean. It's just something that I think is really unprecedented. In the impact that it's had in terms of people's behavior and function. So I mentioned before about home isolation and how we've classified that and trying to get people in and out of the system safely. Strategizing is important in terms of how you manage the patient. So we looked at minimum entry into rooms, but allowing communication of patients by intercoms, allowing the Wi-Fi communication and they can communicate with their families via that mechanism as well. Providing iPads if we had to, so they can do Zoom calls, etc., with themselves, but also psychologists, because we try to refer as many of them to psychologists. A very different event because we do not allow visiting. Clustering tasks are important, limiting and setting times for various events would become important, but also allowing to, as the process continues, but recurrent training. I think one of the things that I really honed on, certainly, because people become comfortable over time. And I think one of the important things is allow people, certainly from the IPC perspective, which will never drop, is to ensure that people are retrained and retrained on a monthly basis. And if you fail training, we pull you out because I think that's important. In terms of early and supportive care, oxygen and weight proning we've done, Chest physiotherapy is difficult for us because we have limited amount and we share them between our main hospital. This is one of the things that I'm really trying to work on and improve for some help from more overseas setting. No empirical antibiotics. Stewardship, I think, has been lost in the early part of this outbreak globally. People were firing all sorts of antibiotics, azithromycin and augmentin and ceftriaxone, and we call the drug because there was a lot of uncertainty and fear. But I think I've really tried to tailor a serious stewardship program back into the advent of COVID-19. No routine steroids, and they're only used in the context of what you were mentioning before from the previous speaker. And of course, you check and monitor comorbidities. And I think this is important. I think this can be lost as we try to fight COVID, that we need to focus a lot on comorbidities of people and understand the psychological effect on individuals. And as I said before, all patients are offered certainly at admission psychological assessments. And I'll go as far to say this, and I think we've used the opportunity to do a lot of technological advancements. So in the past, for most hospitals, and certainly in the Caribbean, you go into the hospital, your records department, they take all your information, etc. We've gotten rid of all of that, certainly in our isolation facilities. So people can really check in before they even arrive at the facility. If they know they've been flagged yellow or red, we will see that information even before the person arrives, able to print it, look at it, and certainly assess it. And if they're not able to do it, we've instituted client. Everybody's not computer literate, so we've instituted what we call client aides, who will at their admission time fill out their forms for them electronically. So it's set forward. So this I'm not going to get into much, but we have a current system of flow. Certainly when people are hypoxic, looking at the indications for intubation, and we try as hard as possible to avoid intubations. We've not had, frankly, honest with you, we've not had very good outcomes with persons who've been intubated. We try to do a lot of high flow oxygen, and we've done that. We have the prerequisite and the right amount of ventilators to do that on the ground. But of course, one of the hardest parts, of course, is that almost every country has limitations in the amount of persons who are trained in this area, which is certainly a challenge. And so what we try to do is we're currently working on really hard, is trying to limit the amount of things that those individuals have to do. So burnout is real. And having a large amount, 30, 40, 60 persons who are ventilated for either invasive or non-invasive ventilation is a very, very difficult task for any one or any 2 or 3 person specialties which you have. So any small things, whether it's putting up somebody who can put lines up for them or do other entities, becomes strategically important. So clinical management, except for no proven real FDA-approved drugs. We heard a lot of drugs before. We've used remdesivir. I know it's not something that certainly recommended WHO. My own IDSA does recommend it only for a certain category of individuals with severe disease, less than 94% oxygen. We've used dexamethasone, and for the same, under the same guidelines as given before. And of course, monoclonal antibodies. I heard the speaker talk about that. And then per se, these are pretty expensive industries that we're still trying to get online for a certain population of individuals. And I always make it very clear when we talk about drug management that all the drugs are not centered towards one group or population. Certainly, but they're specified according to various situations. So people will call me and say, I want to use this drug, I want to use that drug, my relative. And some of them never ever been faced with as a doctor, or not to use this drug or not to do that drug. So it becomes very difficult and taxing and mentally stressful, and many of the healthcare workers are having to deal with that as well. So I'm racing towards the end, but the staff effects I think are important. Maintaining that spirit. There's always a level of fear among the staff. I think people who've worked in isolation have become very comfortable, but becoming comfortable sometimes can work the other side. And so retraining needs to continue. Adherence to IPC protocols. I cannot stress for you how much I think we've done very well in Barbados, certainly, and knock on wood on that one, in our isolation facilities, that if we had 1 or 2 cases coming out, and generally coming from the community and not coming from within, and this is really the trend internationally, that we've not had major outbreaks, major contact outbreaks within the facility, but only for one individual and one direct contact. who travel with that person in vehicle. But I think that certainly is one of our biggest, to my mind, one of our biggest achievements, and really speaks to the protocols, infection prevention protocols, and how strict and rigid they are at the facilities. Psychological assessments are important. Social partnerships and donors are important. Encourage countries to work with the social partnership. And dealing with the social media misinformation is a huge challenge and continues to be a huge challenge, whether it be with vaccination, with drugs which can be used and which are used with misinformation. How do you handle that? Really depends on your local circumstance. Improvements, we've never got everything right. I don't think we'll ever get anything right. Like anyone in the world got this right. But I think where we've faltered a bit is long COVID. Looking at that process is something I will look back at this maybe a year or two from now and say, hey, we could have done better. Vaccine communication strategy, I think we started quite slowly, and I think where there's a void, something else will take that position. I think many of the Caribbean countries, is not a criticism for all of us, I think we made an assumption that our people will take the vaccine without too much hesitancy. And I think that's what probably got us into a lot of trouble based on our previous experience with vaccinations. Variants and identifying them, I believe that many in the Caribbean and many of the countries have the capacity really need to move to that. I know it's an expensive adventure, but I think it would allow them not only to look at COVID, for example, but to look at identification of other antimicrobial resistance data. And then travel protocols has been far and varied and changing across the region. And that has certainly been a challenge, always a lot of debate. There's no definitive stuff. I happen to sit on WHO's panel for travel for COVID-19 for aviation and maritime. And of course, there's always a lot of disagreement in terms of, not disagreement, but I think more discussion about what people are doing and what might be the best thing. I think countries have to do it really according to what's going on the ground. But ultimately, as my last slide, I think we had I would say, not Barbados, we had a little minor hurricane, but we had a knock on wood again, not a horrific hurricane season. This could have been bad or worse, COVID and hurricane. But I think one of the things that I honestly believe, I strongly believe, regionally, certainly at the IPC level, and I've said this ad nauseum, dating back to 2015, that I believe for responses like this, it really needs to be a regional response. And the PAHO has done that very well in terms of coordinating that aspect, but I think countries as well certainly need to lean on these elements, whether it's CARICOM, PAHO, or CDC, come together and have a regional team of experts, a regional team of persons who can respond and assist countries on the ground, much as though it was a hurricane when things get out of hand, so people can put their heads together using both local forces and regional forces who have an idea of what really goes on in the Caribbean to make things happen. Central, I think as well, there needs to be other greater regional cooperation in terms of IPC and infection prevention control. I know many steps have been made towards that, but I think it needs to be really led, certainly from the area of CARICOM, and sooner than later. This will not be the only infectious disease we'll see, and probably not be the only pandemic we might see for our lifetime. Hopefully, I'm wrong. Thank you so much for giving me this opportunity to talk to you this evening.
Thank you so much, Dr. Ford, Dr. Ariel. We would ask everyone to please post your questions in the question and answer chat. Please post your questions in the question and answer chat. It is now that time for us to ask our panel the various questions. So let's go to the question and answer chat. Again, we want to say a special thank you to our panelists and a special thank you to you, our audience, for your attention this evening. So our first question is, what is the purpose of melatonin in the COVID-19 client? Either member of the panel can answer.
Okay, if it refers to the systematic review on pharmacological treatments, I can say that melatonin is one of the interventions that we have assessed. We didn't today, the certainty of the evidence for melatonin is very low. So our conclusion is that we don't know if melatonin is good or not for COVID-19.
Thank you, Dr. Ariel. There was a question about real-time meta-analysis of ivermectin consisting of 65 studies has a conclusion of moderate certainty. The presenter said that the conclusion is low certainty. Can you explain why they have a different opinion?
Well, the ivermectin issue it's a complex one. There are not only two, but a lot of systematic reviews with different conclusions and analysis performed. We found, as I have shown, that there are significant differences in the results of studies that have significant methodological limitations as opposed to those that are more methodologically sound. And that is something that explains why some may conclude differently to us, because some reviews may not assess the certainty of the primary studies in the same way as we did. So, well, that's an issue that it's, I can only explain what we have done, and I'm not in a position to explain what others have done in their reviews. In our case, what we have found is that difference between the studies with methodological limitations and those that they more methodologically sound, and we decided to focus our results in the studies more solid. And if we do that, the results show that ivermectin may probably not have a significant effect on patients with COVID-19. As you already know, there is a lot of controversy around this issue, and in the recent weeks, some studies have been retracted from publication. So this is a really complex issue. As I already say, I can only explain what we have done.
Thank you, Dr. Ariel. The next question is, why can't we give vitamin D to patients with mild to moderate COVID-19?
Okay, so I didn't say that we can't give vitamin D. You can give vitamin D. What I have said is that there is no compelling evidence that vitamin D has any beneficial effect in patients with COVID-19. But if the patient need the vitamin D because it has other problems, for example, I don't know, bone problems, he or she can receive vitamin D. The recommendation is against using vitamin D for COVID-19.
Okay, thank you. We also have a link that was sent based on the NHI versus approach. I guess it can be looked at a later time. Thank you for sharing. We have two attendees with their hand raised. Going to ask the host to please unmute the attendees with their hands raised so we can hear them. Thank you. That is Stacy Bevins and Jacqueline Newbold.
Tanya, they're be able to talk by now.
Thank you. Stacy, please unmute your mic.
Hello.
Hi. Please ask your question, and if you can, to turn down your television in the background.
Okay. Actually, I did not have a question. I'm sorry.
No worries.
Yeah, sorry.
Thank you. Jacqueline, please unmute your mic. Okay, thank you so much. We will now go to another question. Pneumonia implies an infectious process. If the viral phase lasts about a week, what non-infectious pathological process would you say is occurring in the lungs post-viral phase? Autoimmune versus hypersensitivity pneumonitis versus organizing pneumonia, some other inflammatory process, etc. Should I read that again? Oh, Dr. Ford is laughing, so I think I should read it again. Pneumonia implies an infectious process. If the viral phase lasts about a week, what non-infectious pathological process would you say is occurring in the lungs post-viral phase? Panel? Dr. Ford, you can take that question. Go ahead and unmute your mic.
Yeah, I was waiting for the last part. There's a lot of part of the question. So they gave
Okay.
some, very good.
So I'll give the other parts of the question. Autoimmune versus hypersensitivity pneumonitis versus organizing pneumonia, some other inflammatory process, etc.
Yeah, so this is difficult to tell. I'm not even sure how to answer this one because there's still lots of stuff going on, looking at COVID and its effect on the lung, in terms of even its long-term effects on the lung. So I think if I was going to harbor a bet, I think this inflammatory phase which certainly occurs. And I think as what happens in any other viral illness, we even look at what happens in the other respiratory illnesses that happen globally every year. I think it may be a similar type event that happens there. But I think what follows often as well, which we need not to forget, certainly in the bacterial infections, which can often follow viral illnesses, which I think is more important. So of course, it causes the damage that we all know to the lung, but certainly we also have to look to see what type of other infections can follow as well, whether it be staph type infections or strep or some of the other infections, often staphylococcal infections following. I believe it's just a totally inflammatory reaction based on the current evidence that's available, as opposed to hypersensitivity.
Thank you, Dr. Ford. We have another question that says, can we address the lack of science to document the effect that the current SARS-CoV-2 vaccines have on the innate immune system? Either member of the panel can address that. Go ahead, Dr. Ford.
I'm not a vaccine expert, so it's going to be difficult for me to answer. I don't know if anyone can answer. I'm trying to understand the question.
Dr. Ariel, would you like to take that?
Perhaps you can repeat the question, Tanya.
Okay, Dr. Basson, the question says, can we address the lack of science to document the effect that the current SARS-CoV-2 vaccines have on the innate immune system?
I'm not aware of that kind of evidence. So far, the evidence shows that the vaccine is very effective in producing immunity to all the variants we have so far. Don't know if anybody would like to add.
Thank you, Dr. Basson. Another question we have is, as far as you are aware, is mast cell activation syndrome a component of the pathophysiology of COVID-19? I'll read it again. As far as you're aware, is mast cell activation syndrome a component of pathophysiology of COVID-19?
Sorry, I'm not an expert in pathophysiology. I don't think I can answer that.
Okay. Thank you, Dr. Ariel.
I certainly can't answer. I can't answer this one either, but I can say from certainly from reading and my knowledge, I don't believe so. It's a very different question to talk about mast cell activation in this particular aspect. I am not aware of this at all.
Thank you, Dr. Ford. We have some comments saying that the presentation this evening was quite needed, and it was a very good presentation. We have a question that asks, what are the benefits or synergies from using a combination of medication as opposed to singular interventions of the drug study? What are the benefits or synergies from using a combination of medications as opposed to singular intervention of the drugs study?
Well, we have some examples of combinations. For example, tocilizumab was assessed in studies in which patients also receive steroids. So the information we have about tocilizumab is mostly on the combination of tocilizumab and steroids. So that's one. Then we have some trials ongoing. For example, there is one combining baricitinib and tocilizumab that I think that we will have the results in a few weeks. We don't have them yet, but it's an interesting view, and I think that it's something that it's being assessed.
Yes.
Thank you, Dr. Ariel. Dr. Ford, you care to interject?
Yes, yeah, for sure. And I just want to cement what Dr. Ariel has said, and that we've done that. Certainly in my presentation, we've mentioned that in terms of using drug combinations. I think there are many on the horizons. I know the IDSA is about to put out some information on some combinations of some of these agents, which I've mentioned before, which Ariel has just mentioned. So I think the advice to all who are listening, certainly in looking at these agents, is you have to keep your ears glued to the ground, because I think information changes quite quickly. And I think this is very important. You have to keep up to date with what's going on. There are going to be some changes, I know, for participant, for example, in terms of its use, certainly will be recommended by IDSA for its use in persons who are more critically ill as well. And in combination with some other agents. So I think you should keep your ears to the ground for that one. Thanks.
Thank you, Dr. Ariel and Dr. Ford. G. Benaby has their hand raised and their mic is unmuted. Please proceed with your question.
Benaby? Benaby, should I go ahead? Yes.
Please go ahead, Benaby.
Yes, there are two questions I'd like to ask. In the context of where we are with the controversy and dogma with treatment, I think we are reaching a point now with Pfizer and Merck, both developing two drugs. Pfizer developing Paxlovid and Merck developing Molnupiravir, both of which are treatments and will have significant effect. In developing countries where cost is so significant, what intervention, if any, will be made by PAHO to help these developing countries be able to access this medication the way it's being able to be facilitated to access vaccines?
I guess as the PAHO rep, I should take that question. So I'll be honest, vaccine inequity has been a challenge and still is, and that has extended to therapeutics, supplies, equipment as well. It's a challenge, but it's one that we continue to grapple with. We try to use demand consolidation across the region so that we can negotiate good prices and do bulk purchases. We try to negotiate with the countries that have greater access to do sharing. We try partnerships direct with manufacturers. And so it's a multifaceted approach, but it's not easy. That will have to continue. And at this time, really, that's the most that we can say. We've learned some from what has happened with COVAX and trying to purchase COVAX, but we're using the ACTS accelerator and applying lessons learned, and we continue to try and make treatments, vaccines, equipment, supplies available to all countries as quickly as possible at the most affordable price. Over.
Yes, thank you for that answer, but I will suggest that in the absence of some equity in this area, we'll continue to be faced with many challenges.
Thank you,
I don't
Mr.
disagree.
Benavide. Thank you, Dr. Boisson. We have another question. Oh, before we get to another question, Dr. Reyes, you wanted to interject?
Thank you. No, I was actually going to say exactly the same with Dr. Boisson. Just probably going to add that WHO is in conversations with a number of these producers of these medications and trying to increase access for some of those medications, particularly those that were mentioned, the one from Merck and Pfizer. We still don't have all the information of the full publications. So we are currently assessing with WHO data that is of unpublished data and trying to get this data. Based on that, we are going to make some recommendations and some other recommendation of other medications that are going to be recommended very soon. For example, baricitinib. And based on that, we're working on trying to provide access to countries, but as Dr. Boisson said, it's a very complex issue as we all have seen during this pandemic. Over.
Thank you, Dr. Rivas. We have a question in regards to the doses of ivermectin used. The question is, what were the doses levels like? And also, was it administered according to weight, as this may have skewed the effectiveness in producing the measured outcomes?
Well, we have 33 randomized trials included in our review, and the way that ivermectin was used varied significantly between the studies. And well, that's something that needs to be explored to assess if the effectiveness is modified by the way the intervention is implemented. And it's something that we have done, and we didn't find significant differences in that aspect. But that's something far more technical, and if people are interested, they should go to the document and look at it.
Thank you, Dr. Ariel. And I want to remind everyone that the documents that were mentioned during the presentations tonight can be found within the chat and of course on the who.int website or on PAHO.org. We have two more questions before we wrap up this evening. This question is coming from Nicolette. Why is the region not taking natural immunity into consideration for those who have already contracted COVID-19? As studies have shown that the immune response of those previously affected is more robust and longer lasting. Also, a study from Israel showed that those who have had the infection are at an increased risk of side effects. Panel?
Yeah. Can I say something? Sorry, because I've seen many questions regarding vaccines, and this webinar was specifically on therapeutics. And so we have specific experts that can respond in much more detail these questions. And if this is a topic, maybe we can discuss with Dr. Boisson or having a specific webinar on vaccination. And I would say there are very interesting studies that address these questions, and it would be very interesting to present those studies in a further, if you're interested, and we can discuss it in a further webinar. But I would get into specifically the questions of therapeutic and clinical management, because I think that was the purpose of this one. Otherwise, of course, we can do a very detailed one on vaccination, and all the different aspects of vaccination as well. Thanks.
Thank you, Dr.
Thank you.
Rivas.
Yes, thank you. And certainly this is, as I said at the start, a session that the association board thought was of greatest concern at this time, but that doesn't mean that we cannot have another session. And certainly I have also seen quite a few questions on vaccination. So we can consult the board and arrange for a session at another time on vaccination. So perhaps you can just have a quick look, Ms. McFall, to see if we have any questions on therapeutics. I think we've done most.
We have one more question. We can advise. There's a comment about significant obesity as a comorbid negative factor that's affecting the Bahamas and possibly what is seen in Barbados. But there's another question that I want to go to, and it says, are there any holistic and behavioral recommendations about lifetime changes that you would recommend to help persons build their immunity and their health in general so as to be able to fight any other viral pandemics that may continue to plague our people?
I can start by answering this one. As it mentions Barbados. I think, look, obesity certainly, I think from, you saw from the slide they even put up, we had a lot of people who were in, certainly were ventilated or had severe respiratory disease were certainly in that population of individuals in terms of obese individuals. That's something that's commonly seen. But again, that's a large part of people, again, in both of our populations. So I think it goes back to one of the things that has been mentioned many times over and over. And that's certainly in terms of the fact that the whole advent of NCD certainly will also drive the severity of disease that one may see within the Caribbean, and certainly within countries that have a high amount of diabetes, hypertension, and certainly obesity, and that's what it comes back to. So I think although we're looking at COVID-19, I think one of the things that we have to look for, certainly as a region, is how we impact the other things, the NCDs, that often are lost in the conversation where COVID is concerned, recognizing that many of these certainly predispose people to get into severe disease or developing complications, which can certainly lead to severe disease. Example, renal disease, for example. We found that many of those patients have certainly not done well when they get severe COVID as compared to other persons who may not have them or have diabetes or hypertension. And I think regionally that really needs to be looked at as well, how we manage our NCDs and putting the emphasis on the patient in terms of understanding that they're the ones who will control the effect of the disease as opposed to the doctor who prescribes medication. Thanks.
Thank you, Dr. Ford. And a special, Dr. Rivas, please interject.
Thank you. And so I would like to take the opportunity to discuss very briefly two topics that I think are important, and Ariel and Dr. Forgy also mentioned it, because many of the webinars that we participate, the experts tend to focus on not the expert, but the participants tend to ask questions very related to the management of treatments. And I think that's a very important issue. But something that we have noticed is that it's really important to identify early identification of those patients that are at risk and early identification of those patients that are getting complicated. So this is absolutely key. And for doing that, there have been many ways in which health systems have tried to address that. In some countries, for example, in Colombia, they have, and some, in particular, some cities in Colombia, they have a strong primary level. And that strong primary level is able to detect and identify patients because they follow up by phone, or they have nurses or doctors that go to the home of patients, and they can identify those patients that are at high risk first, and then follow up those patients with oximeters and with a questionnaire that they have to try to identify complications. And and this is absolutely key because many patients that are getting complications at the beginning, they don't know they have low levels of oxygen, and they deteriorate very quickly in 24 hours. And so if you don't start the management of those patients, then you are going to get complications. And then this is very linked to one of the questions that was asked here regarding. So one of the person that participated was saying that we should not focus only on randomized controlled trials, and that we should focus on studies, on other type of studies, for example, observational studies or studies that have some biases. And this is really problematic specifically for COVID, because we have seen that for COVID, patients with obesity could have 3 to 5 times more risk of dying. The same for hypertension, the same for many of the other risk factors. So if you're doing a study in which you're having one group more people with high risks than in the other, of course you're going to find difference, but it's not necessarily because of the medication, it's because you have the different comorbidities or ages, or difference in the access, or difference in the time that they got into the hospital, etc. So that's why you have to rely on randomized controlled trials, particularly in COVID, because you can very easily have, if you have one or, I don't know, in one group you have 5 patients with obesity and the other one you have 2. Just because of having COVID, you'll have one more that dies because there is obesity in that group than in the other. And it's not because of the medication. So that's why you need to have larger studies, and you need to have studies that are well done and that are randomized. And this is why it's difficult to rely in studies that are observational. If we were going to rely only on those studies, for example, at this moment, we would not be giving steroids to patients, because at the beginning, the studies on steroids, the observational studies on steroids were saying that giving steroids was worst for patients because those that were worst were receiving steroids. And so that's why we have to rely on randomized controlled trials. And I think this is very important. It is really a key issue. So the strengthening health systems and then conducting very good studies is really absolutely key. Thank you.
Thank you so much, Dr. Rivez, to our panel, to the members of PAHO-WHO, to the Ministry of Health, and the Medical Association of the Bahamas. To you, our audience, we thank you all for this evening. And of course, we want to say a special thank you to our tech team for your support. We look forward to our next episode of our COVID-19 segment with you. Have a great evening, everyone.
Good evening.
Evening. Thank you. Bye-bye.
Bye.
Bye.